Hi, I'm Justin DeLibero. I'm the clinical nurse specialist in the surgical and trauma surgical ICUs.
And I'm Joanna Anderson. I'm the unit-based educator for SICU and Neuro ICU.
And we're going to talk with you today about ventriculostomies and lumbar drains, which you will see in the operating room, in the ICUs, specifically the surgical and trauma surgical ICUs, and in neuroprocedural areas. And there are some specific safety considerations that you want to be aware of. So these devices are used in patients generally with high ICPs. They allow us to both monitor ICPs and they allow for drainage of CSF, which helps us to manage ICPs. The risks associated with these devices are overdrainage or underdrainage. So it's a simple device that works on the principles of gravity. So the drainage device is set at the level of the tragus, and if the drainage device is at the level of the tragus, then the pressure in the ventricles only needs to overcome atmospheric pressure in order for CSF to drain. But if the drainage device is raised higher than the level of the tragus or the level of the ventricles, then the pressure in the ventricles needs to overcome more pressure in order for CSF to drain. So if the drainage device is higher, we have less drainage, and if the drainage device is lower than the ventricles, we'll have more drainage. Risk of overdrainage and underdrainage. If we overdrain CSF, then that can contribute to collapse of the ventricles, and then the brain tissue pulls away from the dura, leading to a subdural hematoma. Underdrainage obviously is important in that if we have patients with high ICPs and we want to drain CSF, if we don't drain enough CSF, then my ICPs will be higher than what we're aiming for. So what we're going to do is go through how to set up the devices and then talk about how these concepts relate to patient management.
Okay, so this is the burette as it comes out of the box. It attaches to the IV pole by squeezing a level on the side here. Squeeze it, and it attaches to the pole. There's a couple extra safety mechanisms in place to make sure that the burette does not come unattached from the pole and as a result change its level in relation to the patient. One way is that you pull the rubber bands like so, and the second safety mechanism in place is this string which you can attach to the top of the IV pole and then cinch tightly in place. So again, if it falls off here, there's something else holding it in the same position. As Justin mentioned, the level of the ventriculostomy drain in relation to the patient's ventricles or their level to their tragus is important for overdrainage and underdrainage. Inside the box will come a level. It's a small carpenter's level. There's a spot on the side to attach the level to. You push it in, and you simply bring it and make sure it's level to the patient's tragus. In this case, I would need to pull it down a little bit to make it level to this mannequin's ear. Once you have it level, you want to make sure the burette is in the right position on the drain itself. So the neurosurgery team will typically prescribe a certain level above the tragus that they want, which of course will result in more or less fluid being drained off. And they'll usually say 10 above the tragus, 15 above the tragus, 20 above the tragus. On the drain itself, it has centimeters of water and millimeters of mercury. When they say 10 above the tragus, they mean centimeters of water. And it's easy to remember because the red will always be in the black. So you can squeeze the burette and slide it up and down like so. So if they wanted it at 10, you would leave it right there. This is the piece that connects to the ventriculostomy catheter that goes into the patient's head. And it will screw into the catheter like that. So this is how you facilitate drainage. The other important piece that of course this does is it measures ICP. To measure the ICP, you need to set up transducer tubing. Just like transducer tubing that you use for an arterial line or a CVP, we use the same transducer tubing, but we do it a little bit differently. There's two main differences in the way we set it up. The first main difference is that we set it up sterilely, whereas an A-line or a CVP or a transducer is set up clean, but this we do sterilely because the risk for infection and implications are bigger. The other main difference is we don't prime it with a bag of saline, we prime it with a sterile normal saline syringe. So I'll show you guys how to set it up. You put on a mask, you grab regular transducer tubing just like you would for an arterial line or CVP or any other pressure. You you need about 3 dead enders, and I find that the kit typically doesn't come with enough, so I usually drop 3 in here. You're also going to use a sterile saline syringe. This differs in a normal saline syringe, is the outside of the syringe is actually sterile. Open them up, drop it in your tube. You'll put on sterile gloves. And since you're not priming with a bag of saline, and you're priming with a saline syringe, the first thing you're going to do is take off the spike and just get rid of that. Also, there's one other piece you're going to take off because you don't need. This piece, of course, is designed so that we can draw blood off an arterial line or CVP. But we want to take it off and remove it because we don't want anyone to confuse it for a place to draw off of or a place to infuse anything through. So you just get rid of it. Then you take your normal saline syringe, get rid of the air bubble, and you prime it. Just have to make sure it's primed in all 3 directions by using the stopcock. When you prime going this way, you have to pull the blue tab while pushing the plunger on the syringe, or water won't pass through it. So once you do that, you can add all the caps. And you're ready to attach it to the system to transduce the pressure. So this particular device does not come with an actual place to attach the transducer, so we've sort of jerry-rigged it. Just like when you're transducing an A-line, you need the transducer at the level of the levostatic axis. In this case, you need it at the level of the tragus, just like we leveled it for drainage. So this being the 0 mark, what we do is we just take the rubber band and use it to attach the transducer, like this. So it's automatically at the 0 mark. So this is, of course, the drainage part that's attached to the catheter. You take your transducer tubing and you connect it to the stopcock right there. The position of this stopcock is important. Typically what you're going to have is, if you are draining, you're going to have it open 3 ways. This will facilitate drainage. This is our patient over here, so the CSF will drain this way. And this is the transducer. So you are draining and transducing a pressure at the same time. The only problem is that while you have it open 3 ways, this pressure will not be entirely accurate because this transducer is transducing a pressure on this side for the patient, and it's also being impacted by the pressure on this side of the system. So in order to get a truly accurate ICP, what you want to do is turn the stopcock off to drainage so that the transducer is communicating with the brain and the patient side only. The reason you might wonder why not just turn it off to transducing altogether, but it's an important safety mechanism. We want this to alarm if it becomes disconnected. We want it to alarm if this were to suddenly change position. You would see the ICP go up very, very high. It would be false, but it would let us know that the position has changed. So it's important to keep it transduced at all times. However, if you want a real ICP, you turn it off to drainage. Let it settle out for a minute and you'll get an ICP. Sometimes you may find that when you have the transducer open this way and you close it, it's the same pressure. That's typically the situation if it's a low pressure situation. If a patient truly has a high ICP, what you might find is the ICP may read 6 or 7 right now, but if you close it off to get the real ICP, you may get as high as 30. So it's important that you really get that real ICP that way. I think that's it for setting it up and transducing a pressure.
So to think about how this relates to general patient management, in the OR, and when you're transporting from the OR to the ICU or transporting anywhere with these patients, we always have the catheter closed to drainage, but as Joanna mentioned, always open to monitoring. And opening to monitoring allows us to alarm. If you're transporting with your patients and the patient develops a high ICP, you can always stop, re-level, and if you need to, you can drain CSF. And I don't know if you want to say a word about how you might manage that.
Sure. If you're not draining, you may not need to have, you don't necessarily, you may not have, if you're transporting the patient's been moved, you may not have the burette level at the right time. But let's say you want to quickly get an accurate ICP, it's totally okay to take the transducer off and put it next to the patient's head. That will quickly give you an accurate ICP, and then you can put it back. It may be quicker and more time efficient to do it that way than to cumbersomely try and put the level of the drain up and down related to the patient's head.
Great. And it is important, if you do decide to do that, always make sure you're putting the transducer back on the pull with the EVD. Neuroprocedural areas, these patients are particularly high risk because the proceduralist is elevating and lowering the table with little consideration for what's going on with the ventriculostomy. And as a provider managing the ventriculostomy, you can't always anticipate what the proceduralist is going to be doing with the table. So you need to have that very much on your radar in these areas. And we have had situations where patients have had overdrainage in neuroprocedural areas and have suffered harm from that. Just general care in the ICU. So you may be walking in a patient's room just to perform a physical exam or to place an arterial line or whatever it is. Procedures and activities that would have almost no risk in any other population. But in order to perform these activities, you're raising and lowering the head of the bed or raising and lowering the bed itself, and obviously that's going to change the level of the tragus to the drainage device. You're best off actually anytime in the ICU to grab the patient's nurse. The nurses in the ICUs and the surgical ICUs are very familiar with these devices. They know them inside and out, and they'll help you manage the device related to whatever you need to do with your patients in the ICU. So I think that covers everything related to overdrainage and underdrainage, but a few words about other general practices with EVDs is the risk for inadvertent access. And this has been identified as a significant problem and reported in the literature from across the country. In one instance, and this didn't occur here, but a very experienced critical care nurse was setting up an EVD and an IV infusion and was distracted in the middle of the procedure. And we're all going in multiple directions at a time. And inadvertently, she connected the IV infusion, it was vancomycin, to the EVD, and the patient did receive the infusion and died as a result. After that event, the company actually changed the tubing. So the EVD tubing itself has this green line in it to help to identify that it's EVD tubing. Also, the draw port on either side has these yellow labels that are labeled as CSF. One of the problems is the pressure tubing that we're using is just our standard pressure tubing, and so there's obviously no special identification of that tubing. With that in mind, we have these green CSF labels, and these should be available to you in the OR. And you want to use those at any stopcock or access point to identify these areas as CSF. What am I missing? Oh, also inadvertent access for drawing samples. So providers have inadvertently accessed thinking that it was an A line. Obviously, this looks very different than an A line, but if you have the transducer, maybe even separated off of the ventriculostomy device, it can look very much like any other transducer. So best practice, again, always follow the lines to the source of origin, but then label EVDs clearly. Anything to add?
I think that's about it.
Great, thank you very much.
Thank you.